Welcome to the recorded session from the Da Vinci Trebuchet public meeting that occurred on September 25th, 2025. This presentation is titled Case Study, Driving Collaboration and Value Through Payer Engagement in Network Exchanges. In this presentation, staff from the Blue Cross Blue Shield Association share their experience of onboarding to National Network Exchange. Their experience provides insight into how payers can maximize their role in national and regional health information and clinical data networks. Blue Cross Blue Shield Association Interoperability legal and privacy team members shared practical strategies for strengthening payer-provider collaboration, highlighted real-world examples of value creation through exchange participation, and unpacked evolving frameworks that impact network design. This presentation and all Da Vinci presentations are offered under the HL7 antitrust policy to ensure appropriate collaboration and information sharing.
Those of you who don't know me, I am the Business Interoperability Lead at Blue Cross Blue Shield Association. And joining me today will be Devi, Shah and Amanda Bast on our legal and privacy team. So I'll let them introduce themselves as they get to their sections. But our goal today was really to share a little bit about our experience as the association onboarding to a national network exchange, eHealth exchange, and share a little bit of insight into some of the similarities to existing contracting processes versus differences when joining a trust framework. So I will go ahead and share my screen and let me know if you guys have any issues seeing anything.
Yes, we can see it.
All right.
Yeah, there we go. Thanks.
All right, awesome. So just wanted to, and is there anything blocking my screen? I sometimes have a Zoom.
The right side, it looks like there is a box covering part of your slide.
Is that better?
Yes, that works.
Okay, thank you. All right, so for our topics today, we'll be covering just some high level, what is the value of joining a network exchange? I know we heard in the last couple presentations from Michael Westover related to clinical data reporting for quality measures and an option for that being national network exchanges, as well as from Scott a few sessions ago about CMS aligned networks and TEFCA. So I want to bring some cohesion to some of those conversations from the payer perspective, and then talk about our experience as the association onboarding, and provide some perspective from our legal and privacy team, as well as share some of our policy priorities that we are focused on as well, that we'd love to get feedback from this group from in future sessions as well. So kicking off with the value of network exchanges, a lot of this is not new to folks and was actually pulled from some messaging we had in 2024. So not a lot has changed besides maybe the addition of the CMS aligned network piece. So the way we position networks to our plans is, existing use cases already drive value, and those can be actualized through network exchanges, things like ADTs, clinical data from CCDs, gaps in care notifications, follow-up care. There's plenty of examples of bidirectional clinical data exchange that can be leveraged through national network exchanges as well. We know that new use cases will need to demonstrate value, things that are being built through the CMS 0057 capabilities. And we know that TEFCA and CMS aligned networks are moving full force ahead. And so there's a lot of value to getting engaged to understand how your organization can participate in those. We do know that the reality of today it relates to data exchange. The option for private networks is still important, whether that's protected by technical or contractual guardrails. That's definitely something that is still top of mind, especially in these early adoption phases for payers. And lastly, access to application services. So as payers are thinking about how their capabilities are going to be used nationally across their populations, things like identity verification and credential management are the participants who they say they're going to be, who will be authenticating requests before providing access credentials. Those are services that payers are thinking through in terms of how they may be able to offload. So in terms of positioning national network exchanges, we're very focused on how can we kind of pave the way for national interoperability today, including the needs for payers while still realizing value, knowing that this is one slice of many activities that we do. So we do acknowledge that, network participation for payers is in transition. There are quite a few things that still need to be figured out. There are aspects of point-to-point that are not going to go away overnight. Workflow alignment and minimum necessary are important to ensuring the data is as expected between both parties, similar to as is done today. Given some of the terms for participation in a trust framework national network exchange related to indemnification and liability limits, minimum necessary is definitely not going to go away as payers are as stringent about open data sharing with providers, albeit maybe for different reasons. And so existing contracts for exchanging data are often already in place for initial use cases or leverage the federal mandate requirements. And we know that things that will enable the ideal national interoperability landscape, like a national endpoint directory and scalable security identity consent mechanisms being implemented, will take some time to sort through. So while we can't let go of things that we know work and protect us today, and we can't wait for things that are going to happen in the future and still require some shaping, we do know one thing, and that is that network exchanges are going to be an inevitable part of the puzzle. And so through participation in network exchanges, really encouraging participation so we can start to figure out some of these unknowns. Ensuring clinical data integrity and usage, provenance is very important to payers to ensure the data is reliable when we're putting it in front of other parties. Things like member, patient, and plan ID. Can existing infrastructure already be leveraged? Some of that infrastructure has already been developed and invested in. Can that be built upon and connected for further diffusion? The concept of a brokered versus a facilitated model. We, in our Blue Cross Blue Shield Association hub model, is brokered, but is there an opportunity or does there need to be capacity for both models depending on the context? Those mentalities and models influence things like identity, security, and consent mechanisms. And of course, reciprocity expectations. Ideally, we move away from catered project-based data, data exchange layered with contracts and individual workflow instantiations to more generic use cases of understood reciprocity, similar to the intention of US CDI. And now that there's multiple use cases to get involved with, there's a lot more opportunity to actualize value and along the way drive interoperability governance both within your organization and the industry. So recognize that there's a lot of room for evolution, and we're sort of all in this evolution phase, but definitely realize that network exchanges are a key part of the puzzle, and what can we do to get ahead of that? So to be part of a network exchange built on a trust framework, one of the newer concepts for payers is the concept of a common agreement. So there are terms that are non-negotiable. So it's not that, based on our experience, it's actually not that different of a journey than what is being done today. So my colleagues and I are excited to share more about that in the presentation. Payers are already using public certificate issuers like DigiCert, GoDaddy, User Trust, or they're using private certs that are issued through internal certificate authorities. So a way to think about it is sort of certificates issued by trust frameworks are the layer in between until things become more widely adopted, similar to using Skype versus FaceTime versus WhatsApp. Sort of depends on what application service that you're a part of, which network, and as adoption changes across those different networks, some of the user needs and the accessibility change along with it. So not entirely the public internet, but not completely closed off to point or private issued certificates is how I like to think about the trust framework model, that we all have some options ahead of us to decide upon. So I wanted to include just some concepts for scalability and network value chains that we considered and we see plans considering when they're thinking through their approaches. We know again that the industry is in transition, so it's helpful to consider some principles, and I've taken these from an article that's about designing scalable digital business models. So just some key components to network scalability that I layered on to a traditional business model canvas as folks are thinking about, existing methods of how they transact and do business versus some of the bigger picture needs when it comes to scalability. So under partners, the concept of which partners are able to enable the potential to facilitate additional suppliers and improve products. So this is really the core of scalability, right? Can you add more users and continue the quality of the product? So a lot of this has to do with learning by using. So a lot of it is contingent on those initial adopters influencing and scaling that learning curve to discover new sources of value and then identify and help adapt or enhance the services, similar to Linux and the other open source models that are out there. Under customer segments. So, more suppliers, how does the number of suppliers and services impact the appeal of the platform? So more suppliers generally is a more appealing platform, allows for complementary products and services, which ultimately, unlock the value of the platform and lead to more of a lock-in engagement. So early adopters can benefit from knowledge and industry positioning and drive some of these key interactions. And then, once adoption momentum is established, it's easier to see network effects build a self-reinforcing dynamic where joining becomes more attractive for multiple use cases. And that's sort of the journey that we're on. Under value proposition, how are non-generic functionalities maintained in a generic platform? A big element of this is, economies of scale and the quality control that comes with it. eBay has rating systems and different, social apps. But even for healthcare, as we scale, data quality is definitely top of mind. I know recently at the HS7 work group meeting, PIQI, the Patient Information Quality Improvement, has an interesting capability to allow customizable rubrics to measure data sets against and provide feedback to that user. So not necessarily conformance, but related to that input transaction. So just ways to think about differentiating as we're thinking about the ultimate value that we need to drive and who can really influence that along the value chain. So essentially, scalability is difficult if networks are enabling customizable capabilities, and so common agreements make sense. And what else about those common capabilities can implementers benefit from? Another important factor under customer relationships, do suppliers being the data sources, disseminate information about platform engagement. So is there an element of how are we learning about how other users are engaging given the different data types, use cases, the different purposes of use models? Are there feedback loops and community building activities to increase engagement and improve the model? Those are important things to consider in terms of how to actualize value. And then lastly, under key activities, technology interrelatedness. So are the different vendors and data suppliers able to create complementing technologies? Modular design is very important. And we're all really advancing FHIR and interoperability. And as payers, we're thinking through things, does this play nice with smart on FHIR apps or other proxies or front ends? Are we beholden to EHR integration timelines? Can the applications, interplay across different networks? And then lastly, under key resources, is there an ability to add suppliers' resources rapidly and orchestrate effectively? I think things don't always move rapidly, but in our world in healthcare, but as we saw during meaningful use, being able to deploy resources for execution and orchestrate those effectively makes a huge difference when it comes to having effective network transactions. So just wanted to give some things to think through as folks are thinking through their own approaches. We titled this a case study because this is just ours. And you might find some learnings from here and some similarities as well. All right, so wanted to share now the meat of the presentation, how we actually onboarded to the National Network Exchange and sort of our role as the association. So a little bit about our enterprise and how we're set up as the Interoperability Solutions team. We have 3 roles: participation and advocacy. So that's why we included the policy initiatives at the end of this presentation. Clinical data partnerships, we partner with different vendors to exchange clinical data. And we do this through the Interoperability Hub. So through the Interoperability Hub, we source data, we route it to relevant plans. We support routing data between plans if they have a relationship in which care is managed and delivered by 2 different plans. And we also support with extending resources to enable CMS 0057 capabilities. So our goal is not to ask plans or the industry to build anything that they wouldn't otherwise. And we really our goal is to support where and how we can to complement and extend the individual plan capabilities. So if they don't want it, we don't necessarily need to build it. A little bit more about the hub in terms of some of the the capabilities we have, by connecting to the hub, you can get to multiple data sources. One of them being eHealth Exchange that limits the connectivity burden to the data sources. We support unique plan capabilities. So some plans have different ways to integrate into their workflow. We can accommodate some of those needs. We do have data transformation capabilities when moving between standards. We have the capacity to enable a longitudinal view with the data that we route and store temporarily. And we do have member matching capabilities using our proprietary prefix model. So we don't use all of these resources in all of our kind of services, but essentially this is what the hub itself can do. All right, so I wanted to share a little bit about how we're positioned in with eHealth Exchange in the broader scheme of things. And, this is a straw man, given it's not a perfect model by any means, but, hopefully gives a little bit of insight into the reality that we're in today. So wanted to share our role and how our plans can connect to us. So as you can see here, we are connected to eHealth Exchange, not the QHIN, just the national network itself. We have not opted into the care quality connected agreement, which is an option you can do through eHealth Exchange. And our plans can essentially connect to eHealth Exchange through us, in which we act as a router and just route the information directly, versus, we're not a directory where the plans connect directly to eHealth or any of the other implementers. We are actually a broker and a router in that model. The plans can, if they have the resources and the desire to connect to eHealth Exchange themselves directly, and we don't require any plans to join, right? So it's an opt-in model. So in this diagram, there could be probably a couple extra arrows here between the plans and the purple QHIN box. Some of our plans could easily connect to a QHIN or a national network exchange, that's and not opt into a QHIN. They could connect through an HIE that they're a part of, through which they either connect to eHealth Exchange or another national network exchange, or they connect to the QHIN through that HIE. So there's quite a few ways to get plugged in here to the national landscape. And, wanted to share just a bit of a visual as folks are, thinking through. You could create one of these for your own organization, depending on where you fit in, to kind of understand, if you're a CMS aligned network and you're sort of in that empty space, a box in that empty portion, how many connections do you need to get to the network of value for you? So, I think in today's world, we might do 5 point-to-point connections and be issued 5 different certificates. In the new world, you might have a chain of 5 certificates or ideally less. So when I'm thinking about how folks are, participating, part of it is getting that very specific value that you might get from a data set or a data partner or a use case. And the other part of it is sort of the scalability component. And, if you're accessing 60% of the market through 5 connections, ideally you're now accessing 90% of the market through 5 connections, or the same 60% through less connections. So I think that's the transition here. A lot of similarities to what we are already dealing with as users and exchangers of data. Just sort of thinking through it during this transition phase as we are all seeking to get to the bigger picture of the national interoperability. So our journey has been not, terribly long, I would say. Considering we are a channel ourselves to the Blues plans as the association, I'd say from that business model canvas, we follow the channel phases. We started with, gathering awareness and knowledge. We joined the Trebuchet weekly workshops, a couple of years ago when things first kicked off. Throughout 2024, we brought in a lot of those insights and actually hosted workshops within our plan community and with the relevant policy, legal, and privacy folks to educate them on the concepts of trust frameworks, and hosted different workshops. We also onboarded to the sandbox environment, which didn't require any contracting, to kind of get a sense of how some of those transactions would work. We started the legal process towards the end of the year, and we started recruiting plans to join the biweekly Trebuchet workshops more often to learn kind of how things are progressing. Coming into 2025, we have onboarded as a participant, which means we went through about a year of completing the legal contracting. We are working through the process of being issued direct trust certificates, and we are recruiting plans to participate. And then, of course, moving forward, we'll be evaluating and engaging usage to continue to push bidirectional exchange across multiple use cases. So, fully onboarded now in terms of ready and willing to participate, and get our plans involved to participate as well. And relatively similar journey to what we go through with most of our vendors in terms of how long it took and the stakeholders involved. So stakeholders involved here, just wanted to give a little bit of a sense of lift and hoops to jump through for each of these. We'll hear a little bit more about privacy from Devi, and risk management. Some of their main concerns were, cybersecurity, insurance limits, and ways that we were able to broach that. Where we're really starting with low volumes, and we're approaching this with ongoing evaluation. So that was something that was sort of just a little bit of different than we expect from traditional vendors, and knowing that this is sort of a new use case. Brand, being the association and the blues definitely seemed to be an issue at first, given the requirements for transparency as a participant in the network. And one of our goals was really to be treated equivalently, to be held under the same expectations as all participants. And part of that is, having our brand be featured in the same way as other participants. And so we, had to work through some of those concerns, and Mandy will talk a little bit about our justification for those, and some of the processes that we put into place. And then, InfoSec was a big piece of the puzzle. They evaluated the way the platform operates, and were able to provide some confidence around some of the exceptions that we were made from a privacy front that we'll talk through in a minute here. But overall, there's 3 documents: the DURSA, which is the Data Use Reciprocal Support Agreement, which is the common agreement kind of equivalent, and then there's the participation agreement that we sign as a participant, and then there's an application for participation, which describes the flow down terms that we need to pass to our participants who are the Blues plans. So Mandy and Devi will talk a little bit about that coming up here. But just some tips in terms of, going through the process. It was helpful to be able to have references to each of these documents, but then pull out some of the specifics that were related to each of these teams, given it wasn't sort of a traditional linear sort of document, and ensuring that we had some controlled and clear processes in place to manage the transparency throughout, was extremely helpful as well. All right, so where we landed in terms of what we're offering to plans, we have a slide like this for each of our vendors that we support through our interoperability hub. We're exchanging only in FHIR through eHealth Exchange. Pretty high level kind of query and response mechanisms, both for a plan initiated query versus a participant of eHealth Exchange initiated query, where we're acting as that broker role. And then our use cases that we're beginning with are clinical data exchange. A lot of that value is already being realized and contracts are in place, as I mentioned. And then payer data exchange, we know that payer to payer and payer to provider can also benefit in this context for our plans. So those are the 2 that we're focused on now, but open to additional use cases. One of them being sourcing immunization registry data. We know eHealth Exchange has good relationships with several agencies. And so is there an opportunity to sort of get national coverage through for our plans for immunization registry data? So a lot of creative ways that we are leveraging national network exchanges, and open to exploring more. And I know we'll hear probably in some future sessions about ways that non-CMS 0057 use cases are being put into place as well. And then just a quick flow for how our clinical data exchange use case is operating. Well, there's a trigger event that needs to be decided upon, and once that trigger event reaches the plan, they know to initiate the CDEX task to us, which gets routed to eHealth Exchange, who queries the provider, and then retrieves that data and shares that back to us to route to the plan. So not too different than the role we serve for other data types. All right, with that, I will hand it off to Mandy, who has an amazing experience with our interplan model and setting up contracts from our vendors to our plans through the statement of work model. So Mandy, I'll let you introduce yourself and hand it over to you.
Sure. Can you hear me okay?
Yes, we can hear you.
Okay. My name is Mandy Bast, and I'm an associate general counsel at the association. Just here to explain a little bit about our contracting with clinical data exchange. So a lot of the DRSA terms will flow down through the statement of work for all of the vendors. And then one of the items that we explicitly added was that the permitted purposes were limited to healthcare operations only. In addition, plans don't connect directly to eHealth Exchange, so there's no passwords, digital security, or certificates from eHealth Exchange are shared. In addition, we included justification for the risk of no indemnification or liability limits, and us as the association assumed most of the risk because the terms were not negotiable, but also we are the ones signing the DRSA as a participant, and we have a direct connection to eHealth Exchange. And that reinforces the importance of minimum necessary. One of the things Karuna explained as well was the importance of our brand, and the use of brand with this initiative aligns with our interoperability goals of increasing data exchange between the plans, as well as our transparency goals. And we believe that eHealth had a great history and track record to work with them. So with that, I will hand it over to Devi to talk a little bit more about HIPAA and the privacy issues that we worked through.
Thanks, Mandy. Devi, Shah here, Assistant General Counsel, and I work on privacy issues for the association. Yeah, I think Karuna provided a really good overview of kind of the system and the various business related issues. And I think on the privacy side, as many of you can appreciate, we did have to kind of rethink how our traditional approach related to privacy and information security terms, with how we work with, this sort of framework, and particularly the DRSA and some of the terms related to the reporting of security incidents. So you'll see here the first part is kind of what the HIPAA security rule requires related to, or the definition of a security incident according to the HIPAA security rule. And you'll see on the bottom that the DRSA doesn't include reporting of attempted but unsuccessful unauthorized access, use, disclosure, and the rest. And so they define adverse security events in this way, and that's what is reported to be what's required to be reported. However, there's kind of this like caveat and nuance here where they don't require participants to report attempted unauthorized access, use, disclosure, because they don't classify themselves as an information system. And so if you look at that definition under security incident reporting under HIPAA, they're kind of saying, well, we don't fall into that category because, we're acting as pass-through, we don't store data. And so, we kind of had to get comfortable with this. It is a different approach than what we've taken in the past in our general vendor contracting, as Mandy noted. And, we did have our information security team heavily involved, and they looked at they validated the architecture, and they did confirm that the way the system is set up, that there is no storage of data and it is a pass through. And just some items to kind of further justify this. Obviously, if we asked if there was a request to modify the DRSA, I think it's a fairly heavy lift. I think there was something that was like all of the participants, blue and non-blue, and just kind of everyone would have to sign off on that, and to change something that may not really be that significant, because having this, like, when you have this sort of framework that we have vetted and an understanding of how the data actually, that it's not stored, it was a lower risk. And the other thing too is that when we have, from the contracting side, when we have an individual vendor, these issues are definitely more prominent, because there's like a network rule, but because there is a network rule and the successful history here of electronic health exchange, we didn't really need to focus on that. There's a huge business value here, and we do have this framework for reporting the successful incidents, which is what really what's important. We obviously are monitoring, the security rule. I know that is coming out, that those modifications will be coming out soon, as well as, transactions that are going through eHealth Exchange, and, making sure that we understand and we can reevaluate if necessary. And, it is a fairly low volume of transactions that are going through. There's a high barrier to entry already, right? There's a whole process to go through. And, we, on the legal side, really do value making business focused strategic decisions, and, want to minimize unnecessary burdens to business and to, achieving those goals. And so, we're obviously supportive of this project, and also supportive of ensuring that the adequate protections are in place. And again, just to reiterate, we do have the reporting requirements around attempted successful incidents. And Karuna, I will turn it back to you.
Oops, was muted. Thank you, guys. Yeah, thank you very much, Mandy and Devi. I cannot thank our legal team enough, and our InfoSec and branding teams, for being exceptional partners throughout this process and the learning curve, and dealing with some of the sticking points. So if folks do have any questions, highly recommend and encourage you to reach out to Devi and Mandy. They have been super resourceful and change oriented and outcomes oriented. So while this is top of mind, definitely reach out if you have any burning questions. And then lastly here, policy priorities. Just wanted to again reiterate that the association has the role of policy and advocacy as well as it relates to interoperability, governance, and driving policies. So wanted to just share a little bit from our policy team, who is unable to attend today, but would definitely be interested in getting this group's feedback on some of the work that they're doing to provide data sharing recommendations to the different agencies. Some of them are listed here. So, as I mentioned, we know things like ADTs add a lot of value already. Are there ways to adapt that through certification to be more widespread? Some areas of HIPAA that could benefit from refinement. Is there opportunities for incentivizing provider to payer data exchange? I think we're more than willing to respond to requests, and looking for folks that are willing to make the requests. How can we incentivize that? Funding payer use case exploration, patient engagement, education, and endpoint directory. Those are all top of mind for us, as well as expanding the TEFCA payer exchange purposes. So they have quite a bit of work put into each of these buckets that in a future session would love to run through this group and get all of your feedback and see how this sort of aligns with the bigger picture. So with that, I will leave some time for questions for us, and hopefully folks have gained some perspective here on how they might be able to fit into the national network exchange world.
Thanks, Karuna. Folks want to come off mute and ask questions? Feel free to share your own experience as well.
No questions. Everyone's ready to onboard?
No questions, but I do want to acknowledge it was such a good presentation, Karuna and others. So, definitely if you can share the content, would love to review it more, socialize it more, but it was a really good presentation. Thank you.
Awesome. Thanks for the feedback. And yes, would love to continue conversations as well if there's, specific use cases you all are interested in.
Yeah, thank you.
Chris, Chaffee, anything you would like to add? I know you all have gone through some of this as well.
Yeah, I have not been involved. I know there have been a lot of discussions around the exchanges internally and at the association. I have not been involved in them directly. I've been kind of having some other interoperability projects going on. So hearing that some actual progress has been made, I know it's a priority of ours to figure out how to participate at some level. So,
awesome. Thank you.
good to hear
for sharing that.
Yeah.
All right. Well, I see a lot of Blues folks on the call, so definitely reach out if you're interested. We have a few going through the process with us right now. And any non-Blues folks or even non-payers, if there's use cases you are interested in, we're starting to collect a log and starting to make them more available and create awareness and hopefully do some of this co-creation together, whether, through eHealth Exchange or if you have a different network exchange that you're working with, we're all going to be working through some of these nuances together. So I'll hand back the floor.